Thank you for the opportunity to present my research. My name is Shinya, I'm Research Director and Senior Embryologist at Takahashi Women's Clinic. Today, I'd like to talk about clinical usefulness of AI-based embryo evaluation model. Currently, most IVF clinics transfer single embryo to avoid multiple pregnancies. This requires us to choose the best embryo for transfer from multiple embryo cohort. Embryo selection is an important laboratory task that determines the time to achieve pregnancy. And embryo selection without PGTA must be more accurate and consistent. Traditional blastocyst selection is primarily based on morphology, which considers the size and compactness of the ICM, number and cohesiveness of the TE, as well as the expansion stage, and is widely used. Morphological evaluation is a simple and effective approach for selecting blastocysts, but it is inherently subjective and can lead to inconsistency among embryologists. We are well educated in embryo grading. However, grading often differs among embryologists. These blastocyst images were morphologically evaluated and vitrified at our IVF center. The blastocyst in the left panel is determined to be 3AA grade, and I agree with this grade, and I also consider it to be 3AA. So what about the blastocyst in the middle panel? Another embryologist defines this blastocyst as a 4BA, but I recognize it as a 3AA grade because it has sufficient ICM and zona pellucida is not seen. On the right panel, I can recognize the strand ICM, but enough ICM and small number of T cells suggest 4AC. But the grade determined by another embryologist was 4BB. Therefore, there is often inconsistency in embryo grading even among the senior embryologists at the same center and receiving the same education. Previous reports suggest that inter-observer concordance rate for both ICM and TE evaluation is not high. Furthermore, concordance rate differ from center to center. This figure highlights the variation in grading consistency across 80 IVF centers. The green-colored areas show high concordance rate for embryo evaluation, while some categories in some centers, such as yellow and orange-colored areas, have a low concordance rate among observers. Incorrect embryo assessment can lead to extended treatment period and the potential loss of viable embryos for transfer. I believe that embryo evaluation should be objective and consistent. To address the limitation of morphological selection, AI and deep learning technologies are increasingly introduced into reproductive medicine. Blastocyst evaluation using AI can analyze embryo images to predict pregnancy potential, and it also enables standardized and objective embryo evaluation, reducing inter-observer and intra-observer variability. A recent prospective multi-center study reported in Nature Medicine confirms that embryo evaluation by AI doesn't improve pregnancy rates compared to morphological evaluation. But it highlighted the advantage of reducing time to observation and consistent evaluation. And recently, various AI-based embryo evaluation models have been developed and are available in IVF laboratories. ERICA is also AI-based embryo evaluation model that allows assessment of pregnancy potential by simply drag and drop single focus, single time point embryo images into the ERICA cloud system. ERICA is learned from a large sample of embryo images and is designed to run blastocysts according to their fluidity status and likelihood of pregnancy. It doesn't require time-lapse image sequences, allowing objective embryo evaluation without time-lapse monitoring. report of the calculated score can be shared with patient or laboratory staff members. However, the performance of ERICA has not fully assessed in clinical practice, and we need to know enough about the performance of ERICA. This is essential before using ERICA in clinical practice. Therefore, we designed a study to evaluate the performance of ERICA in predicting pregnant embryos by analyzing the relationship between ERICA score and pregnancy rate. So we obtained 702 blastocyst images used for embryo transfer at our IVF center and analyzed them retrospectively. The patient and blastocyst backgrounds are shown on the slide. The average patient age was 36 years old. Average age level was 3.6. Of the blastocysts included in this study, 94% were day 5 blastocysts and 5% were day 6 blastocysts. And we analyzed only full blastocysts or expanded blastocysts. The majority of the blastocysts are good morphology. From here, I'll show you the relationship between ERICA score and pregnancy. First, we compared ERICA score between pregnant and non-pregnant blastocysts. The mean ERICA score for pregnant and non-pregnant were 60 and 52, with significantly higher score for pregnant embryos. When the pregnancy rate was calculated by dividing the ERICA score into quartile, the pregnancy rate was low ERICA score group was 26%, while the pregnancy rate for the high ERICA score group was 62%. And the significantly higher pregnancy rate was observed in the group with higher ERICA score group. Furthermore, from low cystic regulation analysis, the odds ratio of the ERICA score for pregnancy was 1.47, indicating that the likelihood of pregnancy increased according to the higher ERICA score. We calculated the AUC by ROC analysis to measure ERICA's predictive performance. The AUC usually ranges from 0.5 to 1.0, with higher values indicating better predictive performance of the model. In our result, the AUC was 0.65, indicating that ERICA has a moderate predictive performance. Here is a comparison with the AUC of our morphological selection criteria. This morphological selection is based on Gardner criteria, including ICM and PE, as well as expansion stage, and also day of blastocyst vitrification also considered. The AUC of ERICA and morphological variation were 0.65 and 0.66 respectively. Our results showed no difference in the predictive performance of pregnant embryos between ERICA and embryo variation, morphological variation. However, because ERICA is objective, consistent, and eliminates inter-observer variability, we believe it is useful to introduce ERICA into clinical practice. In addition, we also compared performance with other AI-based embryo variation models. The AUC for model B was 0.60, and model C was 0.62. Our results show that ERICA's performance was significantly higher than that of model B. Compared to model C, which considers the embryonic developmental process using time-lapse image sequences in the score calculation, the performance of ERICA was comparable to model C. It is very interesting that while AI model C uses more than 7,000 time-lapse image sequences for score calculation for each blastocyst, ERICA showed comparable performance in predicting pregnant embryos with only single-shot blastocyst image. In addition, calculation of AUC were performed on different subcohorts determine the reliability of selecting high potential embryos. This figure shows the AUC and 95% confidence interval for each AI model. In the analysis in the subcohort classified by patient age, the AUC was around 0.60 regardless of age category in all AI models, and there were no significant difference in these AUCs. However, the subcohort classified by embryo grade suggests that ERICA could select embryo with high pregnancy potential from among the top grade embryo cohort. The AUCs for ERICA in the top grade cohort were 0.664. On the other hand, the AUC of model C was 0.57. We emphasize that ERICA has a selection of embryos with higher pregnancy potential from the top grade embryo cohort. And it suggests that ERICA may shorten the time to pregnancy in patients who are expected to have multiple good morphology embryos. In some patients who are more top-grade blastocysts can be filtered. In this case, it is difficult to determine which blastocyst should be transferred. Conventional morphological variation strongly relies on ICA and T observations, limiting the possibility of selecting embryos with high pregnancy potential from top-grade embryo cohort. Our findings also give insight into the utility of ERICA in embryo selection. Conclusion of this study: the predictive performance of ERICA for pregnant embryos is equivalent to morphological selection, but it allows for objective and consistent embryo variation, and its performance is better or equivalent to other AI models. The important aspect of our result is that ERICA can select embryos with higher pregnancy potential from top-grade embryo cohort. Of course, high pregnancy rate can be expected with top-grade blastocysts, but even if the grade is AA, some of the embryos do not become pregnant. I believe that we need to try to reduce the number of embryo transfer cycles and minimize the burden on the patient. That's all for my presentation. Finally, I would like to thank all my colleagues who have contributed to this presentation.